workbook. Not SLPs love worksheets, so if you would like to have that, you absolutely can. We're going to do three exercises that I'm going to give you guys time to actually a few minutes to go through, write things down. So if you want the workbook, Joy just stuck the link in the chat. Otherwise, pen and paper is totally fine. Just brainstorming is totally fine, and your notes app on your phone is totally fine. But just wanted to give you that option if you would like it. Um, Casey, can you take over the waiting room? I was doing that while I was waiting for you, but
Yep, I can do that.
okay, awesome. Thank you. Okay. All right, let's get into it, everybody. Okay, so first of all, I want to say that I really, 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 really want this to be highly interactive. I'm so sick of like webinars and slides, to be honest. Like, I didn't even want to put slides together tonight, but I knew that, there is some stuff that I want to share with you guys, some data that I want to share. But I would love for you guys to type in the chat any questions that you have. Every few slides, I'm going to be asking you for your opinion. I'm going to be asking you to answer some polls, because I really want to be able to help you specifically as best as I can. I know we as SLPs work in all types of different settings, but this topic really, really affects so many different settings. And so I'll give you a little bit of a background, a little bit of an impetus as to why I wanted to talk about this topic. So I'm, just like most of you here, worked in skilled nursing for many, many, many years. But when I was first in SLP, I'd worked in the same facility myself for about 6 years. And, we all, obviously I created the SLP Collective. I'm very passionate about what it teaches, but we talk so much about in order to be a successful clinician, in order to be the best SLP that you can be, you've got to improve your knowledge, you've got to improve your competence, you've got to be able to help patients better. And I 100% still firmly stand by that. But what's interesting is as I've been, working through my PhD and I'm so close to being done, I've been taking some healthcare leadership courses. And what's so fascinating about in those courses is how they talk about nothing about the actual clinicians. It's nothing about PT, OT, nurses, NPs. It's none of that. It's about the actual top-down systems in the hospital or in the skilled nursing center or in home health. That is what drives the success of the clinicians and subsequently the patients. So that's why I really wanted to talk about this topic because I think so many of us, me, especially me, when like I said, those first few years that I was a staff SLP in a SNF, I was working completely by myself. I had no other SLPs to talk to. I just thought it was me, right? I just thought I needed to get so much more knowledge about dysphagia, and I did. But I also realized that there was systems not in place that could have supported me better. And so as I've gotten older and more experienced and learned about this stuff, and I've really in the past 1 to 2 years, I'd say I've really become a lot more passionate about how can we help to be the drivers in this. Some people, some SLPs talk about they love their career, right? They love the place that they work. And a lot of that comes from their facility has the system set up to support their growth. And just because a facility is not set up or does not have those subsystems does not mean they stink. It just might mean that they have not had somebody come in and spearhead those or even identify them. And so that's what we're going to do tonight, actually, is we are going to get down to the nitty-gritty and really identify a lot of those workflow stopgaps that you have going on, and then how can we fix them? How can you be part of the solution? And we'll work through some scripts that you can email off to people in your facility and just start to have these conversations about, hey, this is a problem and it's also affecting the system as a whole. It's also, preventing us from getting a lot more dollars coming in. It's increasing length of stay. It's harming the patient. This is such a downstream problem that I really want us to be part of the solution. And I know we can. So that's my spiel to get started. So tonight, this is called Stop Fixing Yourself, Fix the Workflow. So a systems approach to safer, faster, and smarter dysphagia care. So tonight, you will leave with your number one dysphagia workflow bottleneck identified, one strategic pilot-ready workflow shift, a tomorrow action plan with a simple metric, and AI prompts for documentation and handoffs. So I am going to talk about some AI prompts because I think in cases like this, it can be very powerful. And my little plug for AI is that AI is never going to replace healthcare workers, guys. I know there's a lot of like fear mongering going on in the internet that AI is going to replace everyone, and that's not going to happen. What AI is going to replace is a healthcare worker that does not use AI to make their systems better, right? AI can be so powerful, and especially in situations like this. So I'm going to give you some prompts. And if you are totally like never used AI, anti-AI, you can literally just go to chatgpt.com, use a very free version and stick some of these prompts in, and it will just get you thinking. Like we are not using AI to make to affect patients' lives at all. We are just using this as a brainstorming tool to help you identify some of these gaps. So, first thing I would love is if those of you can share in the chat, where are you currently practicing? Because I'm going to talk about a lot of different settings because, like I said, this affects everybody. But are you acute, rehab, SNF, home health, outpatient, private practice? If there's anything that I'm missing, okay, acute, sniff. Excellent, excellent. Okay, wonderful. Thank you, everybody. Inpatient, some outpatient, some both. Excellent, excellent, excellent. Okay, awesome. Perfect. That's very helpful. Thank you, guys. So you guys are all in the right place. All right. Okay, so why can I not? Okay, there we go. All right, so tonight's flow, like I said, I really didn't want to drown you guys in slides tonight. I only have about 20 planned, so that should just give you an idea there. My goal is to maybe work through some things, have you guys brainstorm on some of these exercises for about an hour, and I'd love to leave a half an hour for us to actually work through some things. So if you want to ask a question or pop on, I can bring you on the camera and work through some things. Like I said, I really want this to be an implementation session for us. I don't want to sit and lecture you. I want you to really have something tangible that you can go into work tomorrow and set into effect. So we are going to talk about some clinical and financial evidence. And the only reason I'm going to talk about a lot of this financial stuff is because it makes such a difference, right? And if you can be someone that affects a massive financial change at your facility, you become the new hero, right? And I don't think we do a good job as SLPs just knowing about what we really are capable of affecting up the chain. And that's not a slight on SLPs at all. It's just sometimes this stuff isn't explained to us. And it's not till we start to hear these buzzwords in the hospital that we realize, oh, okay, what is my role in that? How can I affect that? So that's what we're going to talk about tonight. So clinical and financial evidence, then we'll do some hands-on exercises, like I said, and then at the end, we'll craft your plan and some scripts that you can use tomorrow at work. So like I said, there's the 3 exercises that are in that workbook. If you guys can drop that link in the chat again. If you'd like to download it, you don't need it. You can just use a piece of paper or your notes app will be totally fine. Okay. All right. So now I would love to know, what is your biggest pain point in your facility now? Is it late consults? Like, do you hear about a patient that had dysphagia the day they're being discharged? Is it instrumental delays? Is it documentation just taking you forever? Is it handoff gaps? Like you have no idea where this patient's going, you have no idea where they came from, team confusion, or tell me more. If there's just something about dysphagia workflow that is driving you insane, let's talk about it. A lot of documentation. Okay. Good, excellent. Thank you guys. Obtaining instrumentals. Yep, documentation takes way too long. Okay. Bethany, you have to document diet texture changes in so many places. Okay, that's interesting. I'd love to dive into that some more too, because I actually remember from my sniff days how much that was probably one of the bane of my existence, for lack of a filter on this. Okay, awesome. Thank you guys. Okay, so a lot of documentation mostly. Wait time, some late consults. Okay, we'll dive into this some more. All right. Okay, so I want to talk about some workflow timing changes and how they can affect patient risk, because this all really does matter. Just gotta move some things around on my screen here. Okay, so patients that we're missing with screening, there can be a 3 times higher pneumonia odds without screening. Reduced pneumonia odds post workflow, so there can be an odds ratio of 0.43. and the screening rate increase of 39 to 74% if we put this sort of QI project into effect. So this study showed that dysphagia is significantly associated with post-stroke pneumonia risk, which we all know that, right? A structured dysphagia screening is associated with lower pneumonia rates in acute stroke. And this was a prospective quality improvement initiative that demonstrated that improving workflow design can move hard outcomes. It's not just metrics, right? So it's really why I wanted to talk about this. Okay, so the hidden financial cost of delayed dysphagia care. So workflow delays ripple far beyond the bedside. They impact the operational and financial metrics leadership tracks every day. So you guys might know about these, you might not, but this is why I really want to talk about this because, like I said, you'll hear these buzzwords in your facility, and any of these things that I mention now, I want you to think about. I'm gonna ask you about them in just a minute. Let me know if you hear these buzzwords a lot and if you know how much you can impact them, if you know how much of a driver of change you can be with these. So prolonged MPO status, right? So a delayed eval can lead to conservative diet decisions, can lead to extended NPO, which can lead to slowed discharge readiness, right? Which then can impact length of stay. So, and we also know pneumonia extends length of stay significantly. So workflow inefficiency amplifies avoidable length of stay extensions. Readmission penalties. This was the big thing that I didn't realize how much I had an impact on until I learned more about it. I didn't realize how much the facility I worked at put stock in readmission because they had been dinged so many times that it all of a sudden became like the number one focus of how do we not get these patients readmitted? What can we do? And that was really where I came into play too, of really fixing our dysphagia workflow. My whole thing, our thing was instrumental. So I just could not get them, could not get patients out to them. I was sending them across town an hour away just to get a study because it became such an issue in my facility. So um, readmission penalties, if we have poor discharge communication, can increase readmission risk. The new thing now is value-based care. I'm not sure how much you guys know about value-based care if your facility uses it a lot. But these programs penalize readmissions and they affect facility star ratings. So that was another thing. The facility I worked at, their claim to fame was that they were a 5-star rating, but because we had so many readmissions, they got knocked down to a 4-star rating. And that was a huge, huge, huge ordeal. Quality metric exposure, hospital-acquired pneumonia is tracked by CMS quality programs, and complications affect reimbursement and institutional reputation. So which of these metrics does your facility closely track? What are the big buzzwords that you guys hear a lot? So readmissions. Yeah. Okay. Let me know if you guys can type in the chat if you've heard. Okay. Length of stay, readmission. And I'd love to know if you guys know that you're part of the problem or a part of the solution. Because I think this is just a big thing that we don't talk about as much as SLPs. Yeah. Prolonged NPO, length of stay. Okay. All different ones. Good, good. Okay. Okay. So high risk populations beyond stroke. So post-extubation dysphagia is common and often missed. And I'm just going to zero in on this because I think it's one that really does affect the entire continuum, right? A lot of our patients start in acute, start in ICU, end up with post-extubation dysphagia, but then it affects every setting after that. It can affect rehab, it can affect SNF, it can affect home health, it can affect outpatient therapy. So the systematic review done in 2010 revealed that dysphagia frequency in intubated patients ranges from 3 to 62% across studies. I know it's a very wide range, but we're going to talk about it because it still matters, depending on the definition and timing of evaluation. So delays in identification and communication after extubation amplify risk in high acuity patients. So stroke is about 65 to 78%. So if you are in a certified stroke center, you guys better have a really good protocol for post-extubation dysphagia, for getting those referrals ASAP, right? In the ICU, post-extubation, 3 to 62%, like we just talked about. Frail older adults, up to 68%, and then head and neck cancer up to 75%. So a lot of these really specialized clinics, right, like head and neck cancer clinics usually have very good protocols for how they get their patients in, how they get their referrals. But other settings do not. I think some of the more general settings don't do a very good job at that. Okay. So in your setting, who has the biggest invisible swallowing risk? Is it stroke? Is it post-extubation? Is it for older adults? Is it head and neck cancer? Is there a population that you believe is at risk and you guys are not getting the referrals for them? Head and neck, yeah, all of them. Yeah, thank you, Erin. Okay. Oh, dementia, Lisa. Yes, definitely. Dementia. Yeah, it didn't add dementia in here, but that's definitely a huge one. Excellent, excellent. Thanks, you guys. Okay, good. We're coming up with some really good insights already. Awesome. Okay, so oral care is a systems issue. So this kind of seems like a little rogue topic, like I just went rogue for a minute, but we all know this is all connected, right? And some facilities are really good about having oral care programs, oral care protocols. Some facilities are horrible at that. And I think, and this is really important because, like I said, these are things that we deal with every day. But from a top-down systems level, these can have such a dramatic impact on so many of these metrics that the facility measures. So, oral care is a systems issue. Oh, your QI right now is oral care. Excellent, Catherine. I love that. Thank you for sharing. Um, Okay, so dysphagia workflow must connect to oral care. It's part of the same prevention chain. So the systematic review and meta-analysis, I've read this so many times for a lot of my dissertation work that I'm doing. I've read this study so many times. But oral care interventions are associated with a reduction in pneumonia risk in non-ventilated hospitalized patients, right? We all know that. Authors note a preventative directional effect, causation advised regarding study level bias risk. So this is the systems chain. So there's a dysphagia plan, an oral care order, nursing routine, mobility, pneumonia prevention, right? Sounds simple. Sounds just so simple. But we all know the reality of that is it's not so simple sometimes because if any one of those steps are missed or any of those are not written in a protocol or are not listed in on a workflow or are not listed in the nursing routine or a CNA's chart, then they don't happen, right? So your dysphagia recommendations should consistently bridge to oral care, not exist as isolated clinical notes. Okay. All right. So this next topic I want to touch on is burnout. So burnout is a systems problem and a financial one. And I know sometimes when I talk about this, people get a little angry at me. And I don't mean this from a heartless perspective, only because there's so much data that shows that burnout can be drastically increased from a systems perspective, right? And so this is one thing that, a lot of times people will say, not a lot of times, but I've heard this quite a lot. I've had SLPs come to me and say, I'm so burnt out at this facility. And I'm like, just tell me more, why do you feel burnout? If you're not heard, if you don't feel like you're getting support, things like that matter. But if you just don't feel like you're supported from a systems level, there's nothing in place. Someone said that they have to write diet orders in a million different places, right? Like we've got to fix that system because if you're not feeling supported from a systems level, there's not enough things to support you. Burnout can absolutely happen. So that's why I want to talk about this too, because the system problem really can lead to burnout, which we'll talk about this. So this report from the National Academy of Medicine identifies organizational and systemic factors, not individual resilience failures, which is important, as the primary drivers of clinician burnout. So documentation burden, workflow friction, and role ambiguity are specific systemic contributors. So it can cost a facility anywhere between $20,000 to $30,000 to replace one full-time clinical SLP, right? And that's a lot of money. Like facilities don't want to blow money on turnover because they have to retrain people all the time. There's a 2.5 times higher turnover risk in high burnout units, and that's correlated to a lack of systems, right? There's also an increase in length of stay, which we talked about when staffing gaps create coverage strain. So this stuff is it's also cyclical, right? So workflow optimization is a retention and a financial strategy. It's not just a clinical one. And so those of you that might be in leadership roles too, I want to impress this upon you about why this stuff is so important. And I know, you might be thinking, gosh, I just want to be an SLP and see patients all day and go in and out. And I get that. I totally get that. But sometimes, you may want to have more of a leadership role, or sometimes just you being the catalyst of starting these conversations. You may not have to be the one to create the entire system or create the entire plan. But if you can start these conversations, like I said, with the scripts we're going to do at the end of today, you might just be able to get the ball rolling with the right people that can affect the change. And so that's why this stuff is really important. Okay. So talk to me about, what is your number one burnout driver? Is it notes? Is it delays? Team conflict? Volume of patients? Invisible work? I think so many of you mentioned, yeah, productivity, volume, documentation's what we already talked about. Volume, notes, notes, notes. Yep. Okay, good. Awesome. Thank you, everybody. I know I have a love-hate relationship with that word, invisible work, because I think it's it's like, what does that even mean? But those of us that work clinically know exactly what the invisible work is. Yeah. Okay. Awesome. Thank you, guys. Okay. All right. So documentation burden. I wanted to save this to talk a little bit more about this. Clinical, financial, and legal exposure. Okay. So AHRQ review. Some of you that work in hospitals may know exactly what this is. Some of you that don't work in hospitals might not know what this is. Basically, it is, for lack of a better term, a governing body that measures a lot of these metrics. So the AHRQ Commission Systematic Review catalogs documentation burden as a measurable, frequently cited driver of burnout. So they recognize this, right? We know it's a problem. Documentation burden is linked to cognitive load, moral distress, and after-hours clerical work. The survey study showed that ambient documentation technology use associated with reduced burnout and improved well-being was associated with reduced burnout and improved well-being, which is really fascinating. Talk to me. Do any of you guys use ambient document technology? Do you guys know what it is? I'd like to see what you think first, and then I'll share a little bit more with you. No, okay. If anybody does use it, I would love to know. Okay. Oh, this is fascinating. You guys don't know what it is. Okay. So this is, okay, awesome. Thank you guys. So what it is obviously you can Google it or ChatGPT it and you'll know exactly what it is right away. But think about, sometimes if you go to see a specialist, right? Doctors are actually really good at using this. And they, think of think of the doctors like 10 years ago. They used to just scribe into talk into like a walkie-talkie type thing, right? That's essentially what it is in modern day. There's a lot of clinics that I know about that are using this technology. Of course, a lot of PT clinics because they do everything first, that are using this, but it's essentially like Alexa, right? It's a tool like that that just sits in the background, but it listens to the entire conversation, listens to everything you do, and then spits you out a transcript of what you did, helps, you can program them to get your documentation in a line. So it really depends if your facility is using anything like this, because what's interesting is a lot of doctors are using this, a lot of nurses are using this, but a lot of therapists aren't using it. And so I've really been learning a lot more about this, like I said, as far as PTs go, because they're starting to use it a lot more in their clinics. And of course, there are HIPAA compliant ones. There's ones that are just made exclusively for medical purposes. But the notes that they print out are incredible. Really, really, really great. So, Patty, is this being used in the show, The Pit? I'm 100% sure it is. I don't know what you're talking about, but I've heard people talk about this in that show, so I'm sure it is. But yeah, it's something, just something to consider. Okay. So your provider team uses it, but it's not used by the therapy department. Interesting, Bethany, right? Like, why isn't this? Like, we're the ones that we talk about how burned out we are, how bogged down we are by all of this information. And it's so interesting that for some reason it's just not. And it may be the simplest answer is like because we didn't ask, right? Or like because nobody expressed an interest in wanting to use it. So that's why we're going to identify a lot of these things tonight. So thank you guys for being honest about that. It was one of those things that I knew was not being used a lot, but I didn't realize that it was not being used at all. So Valuable. Okay. So reimbursement defensibility, and we're going to talk a little bit more about this. I know this 92507 thing is a really hot topic. I got a few slides in here about this. I have a lot to say on that topic, so we'll talk about that in just a minute. But strong dysphagia documentation must include functional impact of the swallowing impairment, diet level with clear clinical rationale, aspiration risk description, severity and trajectory, treatment response over time, discharge planning considerations, right? We all know this. We all write this stuff in our sleep. But how can we use AI? How can we get better systems in our facility to help us come up with this stuff every time that we don't have to use our brain power? You know, I'm a middle-aged mom right now. I have very little brain power to remember things like this, right? Like, how can we use this stuff to our advantage with the technology that's out there and available right now? One thing I would love to hear, how long does your average dysphagia note take? Would you say 5 to 10 minutes, 10 to 20 minutes, 20 to 30 minutes, or more than 30 minutes? Okay. Yeah, so just such a wide variability, right? Yeah, totally a lot of variability. Okay. And so for those of you that are taking a long, I used to like, I'm a good writer. I think I pride myself on my writing. A lot of writing things come very easy to me. Clinical writing does not. Clinical writing takes me so long. So this is fascinating. Thank you guys for sharing. Deb tries to do point of access documentation when able. Right. And so that's why a lot of these AI tools are even that more powerful, right? Because they take the notes for you and they synthesize it. And a lot of those you can prompt into, like I just mentioned, those things that we want to comment on. What do our payer sources want to know? How can we, use defensible documentation, right? And you can feed those into the AI and make sure that they are giving you those responses. Okay, and when I say use the AI, I mean one of these HIPAA approved programs. There's a lot out there. I do absolutely do not mean putting patient data into HIPAA, or into putting patient data into ChatGPT. That's absolutely not what I'm saying. Okay. Gary, your supervisor says, quit writing novels. It's tough, right? I mean, it's tough. Like if you have a lot to say and also we want to be thorough with our notes, but at the same time, we're up against a time crunch and burnout. So it's totally understandable. Okay. So I just talked a lot about acute care and ICU, but let's talk just a little bit. We'll just do one slide here on post-acute financial reality, SNF, rehab, and beyond. And I want to talk about this because everything affects one another, right? The cascade starts at the hospital, the cascade starts at acute care, and it can affect everybody down the line. So that's why this is really important. So, accurate dysphagia documentation is not just about clinical quality. It directly impacts reimbursement in post-acute settings. So, PDPM, case mix accuracy, we know all about that jazz. So, under the patient-driven patient model in SNFs, accurate representation of patient complexity, including swallowing impairments, supports appropriate case mix weight and reimbursement. Re Readmission penalties. I talked a little bit about this in hospitals, but it's the same thing. The SNFs get hit pretty big too. Last I looked, it was about $30,000 for every readmission that happened within 30 days in a SNF. So if they were in a SNF within that 30-day window, if they got readmitted back to the hospital, it was immediately a $30,000 fine. That was about 5, 6 years ago. So if that's changed, don't be mad at me. That's just the last thing that was on my brain. But readmission rates, they also affect those CMS star ratings that we were talking about and value-based purchasing bonuses. So poorly communicated swallow plans contribute to preventable readmissions. Therapy justification scrutiny. This is what we're going through right now with 92507. Documentation must clearly demonstrate functional need, patient response, and trajectory. Routine or boilerplate notes increase audit and recoupment risk. And quality ratings impact. Facilities' 5-star quality ratings are tied to outcomes and complications. Dysphagia-related complications such as aspiration pneumonia affect star ratings and referral volumes. Okay, so I want to talk a little bit about this 92507 thing. I'm just going to call it a thing that's going on right now. Because I have a lot to say about it, and I'm going to and I know this probably isn't why you guys came to this talk tonight, but it does obviously it all flows together. I am not okay with the amount of fear mongering going on the internet about 92507 right now, because I believe a lot of it is completely unfounded. Um, can you guys mute someone? Somebody's off mute right now. Okay, thank you. I believe a lot of this fear mongering for 92507 is completely unfounded. Let me give you a little, I won't totally pivot here. I'll just give you a little bit of background on this. The reason this came even is being discussed right now. And if you don't know what I'm talking about, the AMA, the American Medical Association, which is the group that oversees all of the billing codes for everything we bill for. They are specifically auditing 92507 right now because of the vast and very broad general use of it. So if you think about it, we're using 92507 for a 2-year-old with feeding issues. We're using it for a 4-year-old with articulation impairment. We're using it for a 90-year-old that we're doing post-stroke aphasia therapy with, right? There's so across the lifespan, so many different conditions. Everyone is just billing 92507. So there's not a good amount of specificity about what exactly we're doing. I don't think this is a bad thing because I think what it's now revealing is that we as SLPs do a heck of a lot more than bill one code, right? We do voice, we treat dysphagia, we treat aphasia, we do AAC devices, right? There's a gamut of stuff that we do. And SLPs for so long have just gotten into this rabbit hole of bill 92507, bill 92507. That's just what we bill. And we do not do a good job of knowing what other codes are even out there. And this is so different across the country, you guys. And one of the things that I'll challenge you on, I don't think this is part of the talk that I was talking about going into, but one of the things I will challenge you on tomorrow or Friday, type into ChatGPT, tap into chat type into AI, what are the different patient populations that you see, right? What are the age ranges? What are the conditions that you treat? And put in your location because location matters greatly. So all of our billing codes are dictated by our MAC, which is our Medicare Administrative Contractor, if I got some of those suffixes. um, but every region is covered by a MAC. Like I'm in Florida. North Florida has a different MAC than South Florida. There's some stuff they can bill in South Florida, we can't bill in North Florida, and vice versa. And I think that's where a lot of this stuff gets muddied because you'll hear one SLP say, "Oh, just add this. You can add this extra code. Oh, but there's a modifier for it. You can't bill it on the day that you bill this, but you can bill it on the day that you do this." There's so much nuance to it, and it's all regional, right? But why I think this 92507 scrutiny is very good is because what I think is going to come out of it is that we do a heck of a lot more than what we're getting credit for. And that's okay, right? That's a good thing to expose. So I'm not worried about it. I'm not okay with the people online that are just saying our profession is going to be done and over with by the time that this stuff is all fleshed out, because there's actually an entire year before any of this will be going into effect. So I think in the meantime, let's water our own grass, right? Let's actually focus on, hey, should I be using this other code? Or can we get higher reimbursement if we also bill this code? Because that's not a bad thing, right? Billing multiple codes for services that you provide is not only legal, but it shows a better clinical and defensible documentation, right? Because you're actually treating what you're saying you are treating. Sometimes we just use 92507 as such a blanket code and it doesn't really tell the people what we're doing, right? So that's why I think it's a good thing. Total sidebar soapbox that I just went on to, but I wanted to talk about that and I hope that was helpful. I hope that was valuable. I hope that shed a little bit of light onto what is going on out there. So anyways, let me get to the actual slide now. That was nothing that I had planned on talking about. So, okay, with the ongoing scrutiny of therapy service codes, documentation quality is no longer just clinical, it is financial. So clinical reasoning must be visible. Vague or copy-forwarded notes do not adequately represent clinical complexity. Documentation must show your decision making, not just the outcomes. The functional impact must be explicit. Does the swallowing impairment affect the patient's nutrition, hydration, quality of life, and safety? This must be stated, not implied. Treatment intensity must align with need. Frequency and duration of therapy must be clearly justified by the patient's functional trajectory and goals. Routine scheduling is insufficient. And this is just why it's under so much scrutiny, right? We'll just bill 92507 for 5 days a week for 16 weeks, and it just really doesn't show the depth of the knowledge that we provide for these patients. So better workflow equals better documentation naturally. Systems that standardize evaluation pathways produce cleaner, more consistent notes, reducing both audit risk and administrative rework. Okay, so that's the whole 92507 thing. We use 92526 for dysphagia, right? What other codes can you guys tell me some other codes that you might be billing? Because this is really enlightening. I would love if you guys can type in the chat if you can think of any other codes that you bill other than 92507 and 92526. Because the more I've been talking to people about this, it's really fascinating that people are like, I didn't even know that code existed, or I didn't even realize that I could bill that code, or I didn't realize that I could use both of those. And this is about getting us paid for what we're worth, right? And so I'm really passionate about this. I'm going to be talking about this a lot more, but yeah, I would love if you guys could type in the chat if you know of any other codes that you guys use that you get reimbursed for on a consistent basis. Kelly uses 92609, 92520 for Aaron. Anybody else got anything? Okay. We're gonna dive into this a little bit more. All right. Okay. So here is our we're gonna get to our first exercise in just a minute. But let's see here. The systems reframe. So 5 predictable breakdown points. So dysphagia workflow failures are predictable. That means they are fixable. Okay. So our first breakdown point is the referral triggers, right? So this includes things like late consults, inconsistent criteria, no escalation pathway. These are things that can be easily fixed in just an EMR, right? This can be something that as soon as someone comes in with a specific diagnosis that the intake coordinator finds or that, admissions in the ER finds, that it automatically triggers a consult to you, right? These can be very, very simple tweaks. They also can be much more complex, but we'll talk about that. So the financial impact that we talked about is delays time to treatment, extends the at-risk period. Screening escalation. So this can be no standardized screening protocol, nursing uncertainty about when to refer. What was interesting, I worked at a facility that was a JACO-approved stroke center. Every single patient that came in got screened, got a nursing screen did the bedside swallow test, or not the bedside swallow, my goodness, I'm sorry, the 3-second water test, did that, but nurses had no idea what to do and the patients failed, right? So that's a huge systems error right there. The nurses are catching these patients, but then they are not getting passed on to SLP for the full comprehensive dysphagia evaluation, which is what JACO says is supposed to happen next, right? So this can lead to missed aspiration events, increased pneumonia risk. Okay, number 3 is bedside or instrumental decisions. So unclear criteria for fees, video fluoroscopy, bottlenecks in scheduling. This can lead to unnecessary restrictions or missed pathologies, prolonged MPO. Number 4, documentation, which most of you said is such a pain point for you. Redundant, vague, or copy forwarded notes, reasonings not visible, reimbursement risk, audit exposure, poor interdisciplinary trust. And then number 5, discharge and handoff. So incomplete swallow plans, no standard communication to next setting. This can lead to readmissions, duplicated evals, patient harm across settings. So if you guys can share which breakdown point hurts most in your setting, which one of these is really a pain point for you right now? Three, three, 1, 5, 1, 1, 1. Awesome. 5, 5. Seems like 1, 3, 5. Okay. Good, a few of them. Okay. And I'm not saying good, I'm saying good that we've identified some of them. Okay. All right. So we are going to do our first exercise here. So I'm going to give you guys a few minutes to do this. Okay. So I want you to map your current state workflow. Okay. And what I want you to do is just maybe on a piece of paper, just make like 6 boxes, right? Box 1 is a referral trigger. Box 2 is screening and escalation. And then I want you to think about these questions. Okay. How does the consult start? Who triggers it? What criteria exists? Put that in box number 1. Put the answers to that. Box number 2, who screens? What tool? What happens when the screen fails? Box 3, what's the standard process? How long does it take? Who's involved? Box 4, about instrumentals. Video fluoroscopy fees. What's the criteria to proceed? How's it scheduled? Delayed? All of your plates with that. Box 5, documentation. How long does a note take? Do you have templates? Do you have EMR smart phrases? And then box 6, discharge and hand off. If you have the workbook, these boxes are all drawn out for you. If you want to create some little boxes on a piece of paper or just write 1, 2, 3, 4, 5, 6. So I'm going to give you guys about 5 minutes to write the answers to these. Think about all of these because the ones that then we're going to really focus on the ones that you realize are really big issues in your facility. And then we'll come up with some solutions. So I'm going to give you a few minutes to work on that. Okay, how we doing, everybody? Loving to see some of the results in the chat here. Are we good? Do we need more time? I love that this has been enlightening for you. Those of you that might be finished, if you can share in the chat, would love to hear what you guys have explored in this. Courtney realizing the biggest issue is being totally out of the loop, disconnected from the rest of the team regarding discharge and handoff. Yes, completely. I think, one of the two things I just thought of. I remembered when I was working in the SNF, I was so frustrated. Like I was not getting, I would find out about patients coming in with a trach like a month later or something. Like it was so insane. It was something ridiculous. And I finally went into um, I can't remember what his official title was, but what's the word? He went around to all the hospitals and basically recruited patients for the SNF, for lack of a better term, that I can't think of his job role. But I went into his office and I was like, how am I not knowing about these patients that are on trachs? How am I not getting orders for these, all these things? And he's like, well, I didn't even know that you did anything with those patients. You help people with speech. Why would you help them with a hole they have in their neck? And I was like, you've got to be kidding me. And I realized that it was something that they didn't even realize was on their radar. That was something that we do. And he's like, if I knew you had trach experience, there's always so many patients out there in the hospital, but I just don't recruit heavily to bring them here because I didn't know we really could support them. So it's so fascinating, just things that we assume that other people know about what we do that we then realize that we don't, they might not know. And then the other thing too, as far as um, hospital discharge, I used to get so frustrated. But then what I found out was, a lot of times the hospitals don't know either. They don't know where their patient's going. A lot of times, those of you that work in acute care, things can happen so fast, right? Or you may have a few days off, God forbid you take time off, and a patient's discharged and you don't know where they end up going. So just having these relationships with the SLPs within your community can just be priceless. And just being able to call them and say, hey, I just got one of your patients. Not sure if you knew that I got one of your patients, would love to, get access to these notes if you have them. Things like that are just they're small tweaks, but they can be so powerful. Um, yeah, Lisa said having to go through the DOR to communicate with other departments, especially if the DOR isn't speech. Okay. Yep. Completely. Okay. Awesome. Thanks, you guys. This is great. All right. Okay. So exercise number 2. All right. So if you're not done with that one, I want to move on because I want to make sure we have time to talk about some more of this stuff too. So now what I want you to do with this is, so those 6 topics again, so referral trigger, screening, bedside eval, instrumentals, documentation, and discharge handoffs. I want you to rate each workflow box between a 1 to 5 on the dimensions below. So fix the bottleneck with the highest frequency, time, severity, and enough control to move. Okay, so that's what we're going to talk about after this, right? So the referral trigger. So frequency, how often? So how often do you get those referrals? If you guys have a great system, they come in constantly, that's a 5. If you hear about them a month later, you're always asking where they are, the process is horrible and broken, that's a 1, okay? So severity, patient risk. The friction, staff stress, how much does that affect? Control, is this something you think you can impact? Okay. And then we'll tally those all up and get a score for each of these at the end. So then at the end, if you guys can post your top bottleneck number plus 3 words to describe it. So is it confusing, slow, solo? What is that bottleneck? So we're gonna identify it by giving it a number, a rating system, and then we can describe it. All right. So I'll give you guys some time to go through this exercise. Okay, starting to get some numbers flowing in here. Okay, got six, frustrating, confusing, slow. Patty, when rating 1 to 5, would a higher score be a good thing or more of a bottleneck stressor? More of a bottleneck stressor. So if it's like a high frequency that you're missing referrals, it's high severity. It's, you have patients of, say risk or say stroke, which is a high risk, right? That would be a 5. Does it cause the staff stress? That's 5. Do you have control over it? That if it's something that you think you have some control over, that would be a 5. If not, then a 1. Okay. Good, everybody. Referrals. Okay. All right. So a lot of 6, a lot of 1s. Okay. This is good. This is revealing. Okay. All right. We're going to move on here. Awesome. Thank you guys. Okay. All right. So based on your bottleneck score, choose one lever that you think you can move in the next 30 days. Okay. So if there's, one of these bottlenecks was the absolute highest score, let's see if there's something in there that we can fix. Okay. It may be something that I don't want to say that. I don't want to say it may be something that you don't have control over because I really would be curious if we identified the right things, the financial impact that I had, the systemic impact that I had, and we put together the right scripts for you to communicate with the right people. Is this something that you can be part of the change? And I would love to challenge you to test the waters to see if that is something. And if not, then you have 5 other problems that you can tackle after that. Um, yeah, okay, so based on your bottleneck score, choose one lever you can move in the next 30 days. So is it earlier consult triggers? So that might be EMR criteria. That might be something you can go speak to IT about. Something as simple as that, right? It could be something as simple as they can turn something on in the EMR that automatically sends you all of the referrals. And I know that was something that there was one facility that I worked at that half the team saw that as a problem, the other half saw that as wonderful, right? So we would get referrals for so many patients because they were triggered the way that they came in. But the DOR did an amazing job of just, okay, no, that patient is not. No, that patient is not. She would just go through and triage every time in the morning, but it was better for her to see them and to triage than to not know that half these patients were even in the facility, right? Okay, so things like nursing initiated referrals or physician education. Standardized screening pathway. Is this protocol, tool selection, escalation criteria, training? This is probably something you work closely with the nursing educator. How do we put that protocol into place? Bedside instrumental decision pathway, clear criteria for when to recommend. Fees or video fluoroscopy, how do we reduce unnecessary waiting time? How do we talk to radiology to make sure that we, have open slots in there? Whatever it is that your plight is in that area, let's identify it. Documentation templates and smart phrases. Is this something that you could use? Some of those AI tools, some of those transcribing tools, are there smart phrases that you can implement into your EMR? Um, yeah. And then discharge swallow summary and warm handoff. So is that a standard template, verbal confirmation, follow-up assignment? Who do you reach out to about this stuff? What are the connections that you can make with the other hospital SNFs or with the hospital SLPs or SNF SLPs to ensure that that process goes a lot smoother? I know a lot of you had said that's an issue in your facility. Okay. Which of these do you think you guys would be able to tackle first? A, B, C, D, E, or F, based on your bottleneck score, which is the one that you think you might be able to have some impact on in the next 30 days? Excellent. A lot of E's. I love that. A lot of documentation changes. E, F, E, F, E, and F. Excellent. Excellent. Okay. Well, and Bethany, that's a very valid point. So Bethany said she's advocated for years to simplify documentation to no avail, but you do think you can improve the appropriateness of referrals through more staff education. And I think, Bethany, thank you for sharing that. I think one thing that's important to remember too is maybe if you can make some moves in one of these areas, it can give you some respect. It can open some doors to maybe having some other conversations with people that realize that you are serious about affecting the change, that you do know what you're talking about, that you are invested in this facility, you have the patient's interests at heart. You're not just a clinician that's there to clock in and clock out. Like this stuff is really important to you. And I'm hoping that if you can maybe get a few small wins, that maybe that could lead to some bigger wins with documentation. So thank you for sharing that, Bethany. Okay, good. Awesome. Thank you for sharing that, everybody. Okay. Lack of education of higher ups of what we do as SLPs affects a lot of these issues completely, Tova. Absolutely. Okay. All right. So now I want to talk a little bit about AI as operational support. And as I said, like I said before, AI can be such a powerful tool in that the way that I love to think about AI and the way that's really helped me wrap my brain around my use of AI is that I think it can be an incredible thought partner. And a lot of times I just have maybe all these ideas, or I can't quite process them, or I can't think of the most efficient way to do them. And I think AI is just a fabulous tool for doing that. So I wanted to give you guys just some examples of some ways that we can use AI ethically, legally. Um, Obviously, please, please, please check with your IT department and see if there's something within your facility that is HIPAA approved that can be used. You will hear me say this a million times. Do not ever put patient data into AI, into a chat GPT or anything like that. But as a thought partner, it can be so valuable. So there was a JAMA study. Well, and I already shared this with you, but something I do want you guys to explore some more is clinicians using this ADT, the ambient documentation technology, as it reportedly reduces burnout and improvements in perceived well-being. Um, and also, these ambient AI scribes in clinical settings were associated with reduced administrative burden and lower burnout scores. So just wanted to reiterate that. So some AI prompts, even if some of you guys are going through, these exercises, we just did those two exercises. And, some of you said, this is a bottleneck, but I don't think I can have any, affect any change in this, or I'm not really sure of the workflow in this. There's just a lot of things going on. AI is a great tool to use to analyze your workflow. So it sounds pretty meta, but it can be very helpful. So type in what your current workflow is, and then just use the prompt of, analyze this dysphagia workflow map, identify the bottlenecks, patient safety risks, and 3 feasible interventions. Includes key stakeholders and a simple metric for each. And this can be something, don't say, Susie at the front desk is very difficult to deal with, but you can say, this person this respiratory therapist is a real champion for what we do. I'm not sure who the decision makers are for this. Give the AI some help in that, and you'll be really, really impressed by what it can spit back out to you. And like I said, I've just done this for a lot of different things lately. We've actually had to do this a lot in our PhD classes. Which I love, are encouraging us to use AI in this way. And it's been really, really, really helpful to, like I said, just as a thought partner to think through some of this stuff and just figure out what could be some possible solutions that you may not have thought of. As a documentation template, if you just need some ideas on how you can make your documentation quicker, easier, faster, have it create you a dysphagia eval template that emphasizes clinical reasoning, diet rationale, aspiration risk, and instrumental decision-making criteria. I know a lot of our EMRs have smart phrases, they have drop-down boxes. sometimes like my thing with documentation was like I knew what I wanted to say, but I just like couldn't put it into good clinical words. And I think AI can be so valuable with that, not using any patient identification information at all, but with this patient, I am seeing this. Please help me put this into a, defensible clinical documentation. And then same with the discharge follow summary. A lot of times, like we don't know what the next level of care needs to see or wants to see. And I think that's the tough part. Like we're not mind readers, right? And it's not that we're trying to keep information from the next level of care. We just a lot of times don't know. I'm going to encourage you to be part of that conversation. Make sure, go talk to the discharge planners and say, hey, make sure anytime a patient has SLP, has speech pathology, has speech therapy, that you have a summary from us, that you have notes from us that are in there. That will help the next level of care so much. It will help with hospital readmissions. It will help with use those buzzwords, those metrics that your facility works on. We'll talk about that a little bit more in a minute. Are any of you guys using AI in just your normal workflow? I would love to hear if anybody's using it and what you're using it for. Did I say anything that inspired you to use it for something? I'm just such a big proponent of it in the right context because, like I said, I just think it can be such a valuable thought partner. That's just the best way that I can put it. Treatment materials. Yep, that's good. Awesome. Okay, these are great, you guys. Oh, patient education. That's a great one, Joanna. I didn't even think of that. Thank you guys. Oh, Deb said the same thing. Leah, oh, you guys are super helpful. I did not even think of this for patient education, but that's obviously obviously great. Yep, functional activities. Good. Yeah, but just, think about, I mean, the use is just so much more widespread, right? I know, we can use it all the time for therapy activities. We can use it for, especially exercises with our voice patients or our aphasia patients, things like that can be very helpful. But yeah, there's so much more that it can do from the systems level of helping to burst through these work blocks that I think are really, really valuable. Okay, cool. All right. Third and final exercise for the night. Okay. So I want you to come up with a little bit of a plan here. So this is how we're going to craft our language. And I'll give you some good, I want you to do this first, and then I'll give you some really, really, really good sentences to use. But this is also a very, very good use of AI. So this is your sentence formula, your sentence frame. If we blank, then blank improves because of blank. So your stakeholders. So who needs to be involved or informed in this? Which unit, team, or patient group will you start with? What will you measure? Length of stay, documentation time, readmission rates, the biggest risk or workaround. What could go wrong and how will you handle it? So I would like for you guys to spend a few minutes working on this, formulating these sentences. Use AI if you want to. Think about those problems that you identified and think about how we can start talking about these solutions. So I'll give you a few minutes to think about some of these, and then I'll have you guys type some of them in the chat when you're ready. Any of you guys want to put some of your sentences that you've formulated into the chat? Anybody got anything good they want to share? All right, Bethany said, if we reduce time needed to complete the eval documentation process, then the time from initial referral to eval will be reduced because a clinician can see more patients in a day. Stakeholders, supervisor, the provider team waiting for the eval results metric would be length of time needed to complete the documentation process. Excellent, Bethany. I might challenge you, Bethany, to think even bigger, right? Like, how does this affect? Think of some of the bigger metrics that your facility measures, like length of stay or readmission rates. Like, how does this have such an impact going downstream, right? But great start, Bethany. If we can improve handoffs at discharge, then continuity of care improves. This improving patient safety and reducing readmission rate. Good. Excellent, Leanne. Yep. Natalie, if we can get video swallows scheduled sooner, quality of care and satisfaction improves because people can eat sooner. Yes. Catherine, if we educate other staff on oral care, patient satisfaction improves because patients feel clean and have reduced pneumonia risk. Right. Good. Excellent. Yeah, these are great starts, you guys. I would just challenge you to think bigger, right? Think higher, think how does this impact those big buzzword terms that your facility concentrates on, right? That's how you get someone posted that their administrator doesn't have time to listen to them. How can you speak those buzzwords? For some of these administrators, all they care about is length of stay, right? If you can equate everything back to that, or all they care about is their Medicare 5-star rating, right? How can you equate all of this back to that? Okay, let's move on here. Okay, so here is your action plan for tomorrow. Okay. So if you want to fill this in, so your primary bottleneck, so you can use the number from the scoring exercise. And then your strategic shift choice, what's the one that you want to choose to be a part of the change? What is your action that you can take tomorrow? So the specific action you can take tomorrow on this. Who are the stakeholders that you need to message tomorrow about this? What is a metric that you can track in 2 to 4 weeks? So I will measure blank, starting blank. What do you need from leadership? If you need buy-in, if you need a meeting with infection control, if you need a meeting with IT, what are the people that you need their ear? And then what is a follow-up date? Because as we all know, these things don't happen overnight, right? Some of these might take 3 to 6 months before it even comes to fruition, but how can we get the ball rolling, right? Courtney, yes. Casey, can you pop the link for the workbook in here again?
Yep, I could grab that.
Thank you. Okay. All right, so I would love if any of you guys could share what is your first action you're going to take tomorrow? Anybody got something they're going to jump on as soon as they get into work tomorrow? Okay. All right, so here's how we can refine this a little bit more. So I said I wanted you guys to work on that first, and then we're going to refine it a little bit. Okay, Mindy, you're going to decide which screening tool to use. Excellent. Yeah, sometimes we got to make those decisions before we can even figure this out. Good. Excellent. Okay. So, like I said, sometimes we just need to be able to speak the language of the people in our facility. We need to speak the safety and efficiency language that they are looking for, right? Okay. So here are some examples of ways that you can use this. So I'm noticing blank, enter the bottleneck, in our current dysphagia workflow, which appears to be contributing to whatever that is. A small pilot change could improve patient safety and potentially reduce blank. Could we test this on this blank group for 2 to 4 weeks and measure blank? Those of you that are wanting to use AI more for this stuff, if you type into AI, some of your facilities may constantly be doing quality improvement projects. If they're not, this is a really good thing to type into AI and say, hey, I would like to implement a quality improvement project on this bottleneck. And the stuff that they will print out for you is really, really incredible. And that's what you can then go to people in your facility to hopefully get this moving. Sometimes if you call it a quality improvement project, they actually buy in right away. If they think you're just bothering them about something that they don't want to be bothered about, they may not listen. So how can we frame this so that we can get these stakeholders to listen to us in a way that perks their interest? And not that I'm trying to say that they're rude or mean or something. Sometimes if we just don't speak the right language, it just, right, goes over their head. So some key positioning principles. So lead with patient safety, then efficiency. Don't say, I'm overwhelmed and this needs to change, right? We want to speak the language of safety and efficiency. Um, Quantify where possible. So even estimates. So this may reduce NPO days by 1 to 2. This matters to leaders, right? And a lot of this stuff too, you can use AI to pull up some resources, pull up some references. There's a lot of great studies out there that can share this information with you that we as SLPs don't really get a lot of exposure to. I've learned so much of this in my PhD studies that's so valuable. And it's like, why have I never heard this statistic? Or like, I didn't realize that we as SLPs really can be the driver of change in so many of these areas. Sorry, got ahead of myself here. How do I go back? There, okay. Propose a bounded pilot. So leaders approve experiments more easily than permanent changes, right? So if we just want to pilot on one specific ICU for this month, right? And then talk about value-based care. So quality and reimbursement are linked. You are advocating for both. So better systems create safer patients, faster, clearer decisions, more defensible documentation, stronger reimbursement alignment, and sustainable clinicians. So I hope this has been helpful tonight. I was hoping to leave a lot more time for questions, but you guys were so helpful with typing in the chat. Courtney asked for a link to the slides. Yes, absolutely. I'm so sorry that you did not get those. I'm so sorry. Yes, absolutely can give you the slides. Joy, I'm not sure what we could probably just email them out to you guys tomorrow. But yes, we absolutely can do that. Annette, you're going to talk with case management to meet and perhaps brainstorm how we can all work together, improving discharge communication. Excellent. Good. So I hope this has been helpful for you guys. These are things that I've been just stewing over for quite a long time because I think this stuff is so important and it's, for lack of a better term, because it's late and I can't think of what I'm trying to say, but the people that work down that one hallway that nobody ever goes down, you just know that there's like really fancy, important people down that hallway and they're dressed in suits, they're not dressed in scrubs, right? And we always wonder like what those people do. Those are the people that speak these languages and can be part of the change, right? And I'm just, I'm learning so much about this in my PhD and how these healthcare systems work. And it's not that they don't care, they care so much, but a lot of times it's just like apples trying to talk to crayons, right? It's like we've got to get people speaking the same languages in order to get things in motion to go the right way. A lot of times we're asking for things that those people have no idea what that means or why it affects them, right? So we just have to do a better job as SLPs of saying, hey, what I do really matters and it really impacts these things that you guys scrutinize and look at so closely. So listen to me, right? So yeah, Natalie, you said it's so nice to hear we're not alone with these struggles. Yeah, awesome. I'm hopeful that, I didn't, hopefully by not pointing out all these bottlenecks, we're, showing all of these holes in all of our facilities. And that's, not the intent of this talk. It's just, we have to identify these things before we can fix them, right? If we don't know what they are, we can't even begin to fix the solution. So awesome. I'm glad you guys liked this talk. Excellent. If anybody has any specific questions, I'm happy to answer for a few minutes. Let's see. Okay, Gary, let's see. Oh goodness, Gary. Yeah, that's a lot there. That's all really tough. Gary, my advice would probably be to see if you can identify if you can work on one of those bottlenecks, right? Because I know they all matter, but is there one that may be a low-hanging fruit that you can start to untangle? Because I know that it can be quite a tangled web in home health sometimes. Aaron, good question. Any recommendation on how to identify those key metrics in outpatient? That's a great question, Aaron. Do you do you have any idea of some of the buzzwords that you hear a lot in outpatient, or that might be something that you could ask your director of rehab. What, because I'm sure the director has to go to these meetings and talk about this stuff, and they probably don't come back and relay this stuff to you at all. They just want you to see the patients, but it all matters. That would be someplace I would start. I would start with asking your director if there's specific metrics that really matter, outcome measures and caseload. Okay, so outcome measures right away. That would be a really good one. And again, if you're using AI, I would play around with this stuff and just type in different prompts like, how can what we do, this specific patient population, how can I help to show improved outcome measures? How can I improve my documentation? What roadblocks can I help to break through? I think there's a lot there. It's just sometimes it's teasing it out and identifying what that is. And like I know I've said this a million times tonight, but I think AI is such an incredible thought partner for these things because it just helps you tease out things that you hadn't thought of. You're welcome. Okay. All right. Thank you, everybody. We are complete for tonight. If you are a collective member, go ahead and just complete the learner assessment. And then those of you, if you are not a collective member and you would like to join the collective because we do things like this a few times a month, we like to have very interactive, active learning. I didn't mean to say that, it's late. But if you would like to join us at medslpcollective.com, we would love to have you. We'll send you out some emails tomorrow with the slides and the workbook if you missed it tonight. So you can maybe once you're at work, it'll help you go through this and not late on a Wednesday night. But hopefully this was helpful. Thank you guys so much for attending. I think this was really important stuff. So it meant a lot to me that you came tonight. So thank you guys so, so much.